Hello, welcome to Sonography Radiology Training Channel. This series of videos is about umbilical cord imaging. This is the 7th video in this video series with title of Umbilical Cord Masses. I will try to explain all differential diagnoses of umbilical cord masses in a few consecutive videos. This is the 3rd video in this field for explanation of umbilical cord cysts. Umbilical cord cystic lesions originate from embryonic vestiges remaining as a consequence of the incomplete obliteration of the urachus and omphalomesenteric duct. An umbilical cord cyst is a fluid-filled sac that forms in the umbilical cord during embryonic development detected via prenatal ultrasound, as you can see in this image. There are two types of umbilical cord cystic lesions: true cysts and pseudocysts. True cysts formed from remnants of early embryonic structures like the allantois or omphalomesenteric duct. But pseudocysts result from a focal area of fluid or edema or liquefaction of the Wharton's jelly. Wharton's jelly is the gelatinous tissue that surrounds the umbilical cord vessels. You can find full explanation about prenatal assessment of Wharton's jelly in this video. Detection and diagnosis of umbilical cord cysts is possible by prenatal ultrasound. Most cysts are found incidentally during a routine ultrasound. They are more often single than multiple findings and are usually isolated, even though their association with other congenital anomalies, usually of the gastrointestinal tract and other syndromes and sequences, has been described. Distinguishing between the true cysts and pseudocysts can only be definitely determined through histological examination of the umbilical cord after birth. This ultrasound image shows a 24 weeks gestation fetus, and as you can see, there are multiple umbilical cord cysts. All prenatal evaluations, including anomaly scan and fetal echocardiography and also chromosomal study, were normal, and a term fetus at 40 weeks gestation is born by vaginal delivery. This image shows the appearance of the umbilical cord after birth. An histological evaluation demonstrated that these cyst-like lesions are pseudocysts due to liquefactions of the Wharton's jelly. Prognosis and associated conditions. Early resolution. Many cysts found in the first trimester disappear by 12 to 14 weeks of gestation and are not linked to adverse outcomes. Persistent cysts. Cysts that persist into the 2nd and 3rd trimester are of greater concern and may be associated with fetal structural abnormalities or chromosomal conditions such as aneuploidy. Potential complications. Large cysts can sometimes compress umbilical cord vessels, potentially leading to fetal growth restriction or other complications. You can find full explanation about fetal growth restriction and small for gestational age fetuses in these videos. Management. A thorough evaluation is recommended at diagnosis, including anomaly scan and fetal echocardiography. If a cyst persists into the 2nd or 3rd trimester, further tests may be needed to check for chromosomal abnormalities and structural anomalies. Clinical management depends on the cyst characteristics, including type of the cyst, means true or pseudocyst, size of the cyst, and location with compression or umbilical vessels or not, and the presence of other findings. If we want to present a rapid guideline for umbilical cord cysts, we can say they are uncommon. We have two types, including true and pseudocysts, Prenatal diagnosis is possible by perinatal ultrasound, which we can find a fluid-filled sac, and single cysts are more common than multiple. About prognosis and associations, the umbilical cord cysts that show early resolution up to 12 to 14 weeks has no any adverse outcome, but persistent cysts into second and third trimester may be associated with fetal anomalies or chromosomal conditions like aneuploidy. Large cysts with compression to umbilical cord vessels may be associated with FGR or small for gestational age fetuses. Management, including prenatal assessment by anomaly scan and fetal echocardiography, karyotyping may be needed if we have persistent cysts into second and third trimester, and clinical management is depend on cyst characteristics. Now, I suggest two others of my videos that are close to this video in terms of matter. And thank you for your attention.